Welcome to the To Your Health podcast, your go-to source for everything health, wellness, fitness, and the latest medical insights. Joining me today is Dr. Brett Casey, an orthopedic surgeon at Gulf Coast Orthopedics and Terrebonne General Health System, and his patient, David Terrio, who is a nurse practitioner and hospitalist at Terrebonne General. Welcome to the show, guys.
Thank you.
Thanks.
All right. Well, so glad you could be with us today. Take time out of your busy schedule. Dr. Casey, tell us a little bit more about your role at Terrebonne General.
Well, I've been a staff orthopedist here for going on 22 years. I treat basically anything that comes through the hospital, general orthopedics. I tell you, I think the bulk of my practice has become joint replacement and shoulder and knee arthroscopy, but we still do just about anything that anybody needs treated. So it's fun to be here, and I'm happy to be at the staff. I've never worked anywhere else, so it's a great hospital and great people. So happy to be doing it still.
Us, we're glad that you're still with us too. And David, tell us a little bit more about yourself.
I'm a nurse practitioner here with hospital medicine, but I was invited as a patient to talk about my experience with knee replacement. And so I'm happy to share my experience because the more you talk to people, the more you find out everybody's got their own journey and their own story. And I'm happy to share mine.
You're going to share yours with us today. Okay, well, let's get started with our conversation about knee replacement surgery here at Terrebonne General. And Dr. Casey, we'll start with you. Tell us, what is a total knee replacement?
A total knee replacement, and there's a little model here, kind of give you an idea.
Yeah.
It's actually three components of the knee. You have a femoral component, a tibial component, and then there's a patella that sits on top. And usually you need these when the bones wear out and there's no cartilage left on them, and because the bones are exposed, the patient experiences pretty significant pain. So as a surgeon, we'll go in and we will take and cut these bones in these shapes roughly, and then you resurface the joint with the metal components and then this plastic spacer in between. And the theory of that is that there's no more exposed bone, so the patient's pain goes away because the bone doesn't rub on the bone anymore.
That can be very painful, right, David?
Yes.
Tell us about your experience with that.
It's a gradual process, where you have pain after you run or after you play basketball, whatever it is, work in the yard. And then over time, it gets to where even normal activities, you have more pain to the point where you're calculating how much activity you're going to be able to do, like to join a family event or something. So when it got to that point, that was time to get with Dr. Casey and start planning how we're going to control this pain.
So, Dr. Casey, when did you first start knee surgeries, and how have they progressed through the years?
I've done all sorts of knee surgeries, but I guess we can break them down into two types: of open surgeries, which are your total knees and trauma type cases, and then scopes or minimally invasive surgeries where you look inside with the camera. Mm-hmm. I would say that the implants have gotten a lot better. I started my residency in 1999, so I've been doing these procedures since that time, and once again, since here in Terrebonne, Parish, since 2004. I will tell you that the implants, particularly the plastics, have improved tremendously. The biomechanics as well as the components that they put in have become resistant to heavy wear, last longer. I would say that the basic total knee is still done pretty close to how it was back then, but the implants have improved their design and their longevity.
So is that the newest technology in surgery?
Yes, absolutely. There are different ways to put them in, but the implant itself is up to date to the degree that it can be right now.
So what are some of the main indicators that you look for before performing surgery?
Well, I think David hit it right on the head. When your activities become limited on a daily basis, and when the quality of a life decreases to a point that you avoid the activities that you like to do. Pain, there's also deformity. You can see people with knock knees or bow legs, and if they're limping, the deformity kind of plays into that because you can correct that deformity as well. You look at x-ray findings, which show bone-on-bone changes, and failure of conservative management. So, David came in and we tried injections, we tried bracing, we tried anti-inflammatories. All these things were provided prior to doing a knee replacement, and they just weren't providing sustained relief. So at that point in time, it's safe to proceed with the knee replacement.
Right. So you try other things before doing surgery.
Absolutely.
David, were you hesitant about having this procedure done? And if so, why?
I think mentally I was prepared. Eventually I was going to need knee replacement. I had been told that at a much younger age. One of Dr. Casey's former colleagues, Dr. Billy Kennard, had done an arthroscopic surgery on me and said, look, one day you're going to need knee replacement, but right now you're too young. So we just have to get through, however many more years, which I never knew what the age was going to be. But I knew when I got to the point that it was really interfering, with my daily life, I got with Dr. Casey and we started making some plans, how we're going to control this.
What was the recovery like, especially the first few weeks?
I think part of it is mentally being prepared. Dr. Casey said, you're going to hate me for 2 weeks, but I never hated it.
Right.
But anyway, the recovery, I think physical therapy was huge part of that. In the hospital, Terry was a physical therapist that worked with me. When I first went home, I had my physical therapist was Garth that came and we did some work at home. So I went from walking with a walker to walking with one crutch. And by the time I went to physical therapy, my physical therapist there was Ryan. I walked in there with no apparatus or anything. And he basically taught me how to walk again with not using any of those things.
How long did that take where you were able to walk without assistance?
In that 2-week period, I had gotten to where I didn't need any artificial help or anybody to help me.
They get you up right away, don't they?
Yeah. Yeah, there was one
and
point
at 'em.
where I still had some swelling and I wasn't bending it to Dr. Casey's satisfaction. He said I need it bent 90 degrees, and if you don't bend it 90 degrees, I'm going to bend it for you. So that was my motivation. I told my physical therapist, we got to get this thing bending. And he was already working on that, but I think a little bit of swelling was keeping it from going, to the degree that we were shooting for. But I think that's the key is being really involved with your physical therapist.
And you were back to work relatively quickly also.
Yeah, surgery was in June. I went back to work in July.
Is that the case with a lot of patients?
A lot of people, depending on their job, but most people are good to go at 4 to 6 weeks. They still ache, but they can get around and do what they need to do.
And Dave, you're pretty much on your feet a lot.
Yeah,
So,
I'm fortunate that, my work is walking and, seeing patients, guys that, do real physical labor, crawling or climbing in holes or up ladders. I'm sure that's,
different.
A challenge to get back, but you can do it.
Can do it. Well, Dr. Casey, what is your ultimate goal for your patients?
Well, get back to the activities they want to do. Once again, we go back to the same thing we talked about earlier, that when it's limiting your activities and your quality of life, it's time to do something. And if there's a solution, and in this case, a knee replacement, then we can go ahead and proceed with that. But, it's close monitoring the patient. My greatest wish in their recovery is that they feel like their post-op visits to me were a waste of time. And I mean that because I'm watching for problems, and I hope there's no problems. Sometimes and just like Dave was saying, we have to take the patient and force them to bend their knee. Sometimes they get blood in the knee. And so that's all what the post-op course is for. But those are rare. And so we want the patient to get back to doing activities. And, I'm kind of a stickler in the first 6-8 weeks. I mean, I force them to bend it. It's tough love, and you need that in this situation. There's going to be pain. But if you get your motion, get active fast, then you're going to do well and you're going to be happy with the result.
Yeah. Why do you think patients wait so long? I mean, a lot of people suffer and they're in pain for so long before they actually do something.
Well, there's some truth to you're a little too young. And what we look out for is as we do one knee replacement, and then if you have to redo it again, the patient loses bone stock each time. So you have to tie into something else. So we don't want to use up that bone stock. But I have gotten a little more aggressive with if you're truly activities are limited and you have bad pathology, then I'll go ahead and do it with the caveat that we may be redoing this. You know, if you're 41, we may be redoing this at 58 or 60. And then, you know, as long as people live again, we might be redoing it again at 81. So those problems have been somewhat limited by the improvements in the implants, particularly the bearing surfaces, the plastic, but it's still there. And so we try to push patients to at least where they have a deformity and bone-on-bone findings. But once again, that's not hard and fast for me. If your activities are limited and you have the disease, then I'll probably proceed with the surgery.
Yeah. Well, David, how has your life changed since having the knee replacement surgery?
It was one of the best things I could have done health-wise. You know, when you're not able to be mobile like you want to, it's hard, you know, to have a healthy weight. It's hard to, you know, do exercise, do the things you enjoy doing, working in the yard, chasing your grandkids around, you know, whatever it is, going with them to Disney World or, you know, whatever it is. And so I never from day one after surgery had any regrets that I had the surgery.
What can you do now that you couldn't do before?
I can work all day in my yard. I used to have, if I would cut branches and drag them up to the front of my yard to get carried away, maybe I could do it for half an hour and I'd have to go sit down, and the pain was, you know, you had to sit down and rest. And I can do it all day now and never stop.
What would you tell a person who is reluctant to seek care for knee replacement?
I kind of get this enough, and I always tell them, well, you're supposed to be reluctant or a little afraid because you don't have control, and most people don't have a thorough understanding. And I always frame it, say, well, you know, when you get in an airplane and you're scared, you know, yeah, do you want to fly a plane? Like, no, I got to trust a pilot. I don't know how to fly a plane. It's the same thing. You know, you gotta trust the person you're dealing with. The surgeon is going to give you the recommendation and guide you through the process. And that relationship with the patient is very, very important because they do have to trust you, and they do have to have the feeling that you know what you're doing, you have their best interest at heart. You're supposed to have a healthy respect for going, you know, altering your body mechanics and messing with the tissues. It's natural. So it's not wrong to do that. But knowing that if I tell you you need it or it can help you, then it's going to. And, you know, you just put the things together and say, look, I've done a bunch of people with the same findings, the same problems, and they've done very, very well. So I try to pacify their concerns with the fact that you're not the only one that has this, and that if you trust me and you like me and you want me to do the work, then I'm not going to steer you wrong. And most of the time, some people are just dead set they won't have surgery. And then I can tell you a bunch of those, when they finally give in and do it, they're like, I should have done this years ago.
Exactly.
So you get a lot of that, but you know, this is an operation that's not life or death. This is a quality of life, and I think those operations are best undertook when the patient feels they're ready to do it. So I don't really push too hard to get you to do it. I let you make that decision on your own.
Right. All right. Well, thank you so much for sharing your story, David, and for sharing your expertise, Dr. Casey.
Yep.
We appreciate it.
Thank you. I appreciate it. Thanks for having us.
For more information on orthopedic surgery at Terrebonne General Health System, visit tghealthsystem.com. Don't forget to like, share, and subscribe to our podcast where you get your podcasts. Thanks for joining us.